So the session is in place and being recorded. This is the Wednesday Cardiology Case Conference, June the 8th, 2016. And this is our first presentation with a patient present who is interested in discussing her case, as well as a surgeon coming in and looking at her case as well. So Dr. Didier Lemay will be coming in from New York University in a little while towards the end of the conference to participate a little bit. So we'll go to our first slide. Basically, this is Susan, who's a 59-year-old divorced female who's an MRI CT tech in St. Petersburg. She's originally from New Jersey. She has a history of a heart murmur. Susan, how long have you been known to have a heart murmur?
March was the first I was told.
So one of her doctors picked up a heart murmur in March, and he's a good listener, and he never heard it before, so we would think that something new had happened to her heart, that a murmur suddenly became present. She also has had the onset of some symptoms over the last month or so that are new. These symptoms are fatigue, falling asleep, palpitations, sometimes tightness or heaviness in her chest. So Susan, could you tell us about your symptoms a little bit?
Well, the tightness in my chest, I thought it was anxiety. I really had no idea. It comes and goes. I haven't had it for a couple of weeks, but when I have it, it's more of pressure in my sternum, tightness, like someone's stepping on it. And the fatigue is just very new because I'm usually unable to even take a nap. And I nap. I'm tired after work. And I can't wait to get through the day, basically. And that's not like me at all.
Susan, can you mute your speakers there on your computer so that we don't hear it repeating?
Oh, okay. Let me see.
See if you can do that.
I think I just did it.
Okay. You did. You succeeded. Okay,
Okay.
Susan, that's great. So, Susan, tell us about what happened about your mitral valve and why you decided you were going to go to Northside and get some tests done.
Well, I went to my internist who recommended 3 cardiologists, and I also asked the rheumatologist to down the murmur, and I made actually like 3 appointments because no one was available. And the first appointment was with a cardiologist that told me, without looking at my images and with only a preliminary echo, that I needed open heart surgery immediately, and that my pounding in my chest was my heart pumping and it was going to burst. So I proceeded to leave when I started to ask questions, and he told me I talked too much and asked too many questions. So then I went to the next cardiologist who works at a Northside, and he said the murmur is very severe. He looked at the images, and he said you need a CED so we can see more about it, and you need a cardiac cath. And he wanted to do that immediately, but I put that off for about 2 weeks, and that's why I had that done. Because I was told that that's what I needed to get a proper diagnosis.
And so how did those things go for you in terms of you as a patient having this done to you, since you're a tech and used to doing things to people with CTs and MRIs?
Well, I had no idea I could have a CT MRI. I have never done cardiac MRI. However, it was extremely invasive. With all the drugs I had, I was out of it for probably 2 days because I go into anaphylactic shock with contrast. So I was heavily pre-medicated the night before, the morning of. Then they decided to do it again to pre-medicate me. So I was pretty woozy before I even had the anesthesia. And that was bad. It's been a week ago, Friday, I still have not heard from a doctor. I did not have a doctor talk to me after the procedure. So I'm not real happy with that situation, but, and I obviously didn't need a cardiac cath, but I did what I thought was the right thing, and that's what I was told to do by a few people. It wasn't just one, but that's the diagnosis. That's how you get a diagnosis, because you have severe mitral valve regurgitation. That's what I was told. So I wish I didn't do it, but I did it.
So the point that Susan's making is that when she came over here, she found out that she could just have a CT and an MRI, and that's all she would need. Of course, an echo. She wouldn't need the transesophageal echo because the MRI takes the place of that. She wouldn't need the cardiac cath because the CT takes place of that. So she had no way of knowing that and was never offered those alternatives. Of course, we've been doing that way. We've been doing it since 2004, so we've had a lot of experience. 12 years, I guess, we've been doing it that way. So it's not something that's brand new. It's something we've been doing for a long time in anticipation of robotic surgery. Tell us why you want robotic surgery.
Well, I don't want a couple reasons. One is because of the recovery. I support my daughter in college and myself, and I can't afford to be out of work for 3-some months. And I'm concerned because I do have severe osteoporosis because of all the steroids. I'm concerned about the healing of breaking bones. So robotics seem like the best. Can get the job done as the other ways, and I won't be laying around for 3 months with hoping that my bones heal. So to me, it's more getting back to life quickly and financial, that I just can't afford to be out of work. And I have no disability. I come from New Jersey, where they have state disability and long-term disability. I did not know Florida didn't have that. My employer doesn't have it. I actually applied when I moved here, but because of the murmur, I can get no disability insurance of any kind for anything heart-related. So this kind of threw me with that situation. I was trying to take care of it when I found out about this disability situation, but now I'm not eligible.
Okay, tell us a little bit about your Wegener's granulomatosis and how that presented and what all this means about you.
That presented for a couple years, a year. I was just sinus infections. The right side of my eye would tear. The right side of my face would swell. I had all strange symptoms, and I went from doctor to doctor, and they put me on, everyone thought I was on a lot of antihistamines, thinking I had an allergic reaction, but I thought why do I only have it on one side of my face? My eyes would get very red and bloodshot, like I was on drugs or something. And I was put on steroids, on and off, while different doctors were trying to figure it out. And then I went to an ENT at Jefferson, and he looked in my nose, and right away he asked me about my cocaine use. I said, well, I've never done an illegal drug in my life. And he said, well, if you're not a cocaine user, I think you have Wegener's. And that's how that started, and he sent me to the rheumatologist. But I know I test negative for it, but I was on steroids for like a year before, or a year and a half before I even met the doctor in Jefferson. So just from my appearance, and I still had the ulcer, they put me on other medication, stronger steroids, got rid of the ulcers, and I've been treated since then, since 2012. And I weaned off of the steroids. The past year, I was like skipping days with the consent of my Jefferson doctor, and he could just cut them in half and skip every other day because I was dependent on them. My whole face would swell up if I stopped. Now I am off of them, and because I had to, because they're ruining my body. And I didn't think I could because of all the effects, but now it seems like it's working out because I am not on them at all.
And how long have you been off of the steroids now?
I've been totally off of them since, I'll say, February, so I haven't had any. But up until that point, I was doing maybe, 6 months before, maybe 3 times a week, half of a pill, which is, I think, was 2.5. So I can take 5 milligrams. I would cut it in half. And occasionally I would take the 5, but I would just cut it sometimes once a week. The max would be 3 times a week. And then I decided when I got to Florida I had to get off of them, and then my Jefferson rheumatologist said, just don't totally stop, just let it out, and that's what I did.
And how long were you on the low-dose steroids?
Probably, well, I've been on the low dose probably a couple years.
The 2.5 or the 5?
Yeah, at the 5, I've never taken more than 5 in the past 3 years.
Yeah.
And the past 2 years, I was 2.5, and when I was taking them daily, it was 2.5, and then you would say, if it starts to get bad, go up to 5, but it was mostly 2.5. The high steroids was in the beginning when I was being diagnosed, like around 2010, 11, 2012. That's when I was taking higher doses.
I see. Okay. And so that's good because that won't pose a problem for healing since it was only low dose for the last couple of years. And so that's actually, it's almost physiologic. I mean, you make your own steroids and you probably make about 5 milligrams a day. And so 2.5 is not much at all.
Well, that's what the rheumatologist in Jefferson was telling me, that it was so minimal. That he just said, because he was saying continue to take it because it won't hurt you. It's so minimal. I said, but I just wanted to stop it. I fear it's done enough damage if it ruins my bones. So I just decided to get off. Good.
Does anybody have, of course I'm asking about the steroids because if she's going to have surgery, well, I want to make sure that she can heal well and the tissue isn't going to be a problem because of long-term steroid use. But the last steroid she's been on the last couple of years has been low dose, so it shouldn't be a problem. And she's been off them a couple months now. So any other comments? Anybody would like to ask Susan any questions while she's here?
Yes, Dr. Harrison, this is Janet Mora. And Susan, thank you for being on the call today. It's very nice to hear about your story. My background actually is cardiac surgery nursing and then cardiac program leadership. I run a nurse navigator program now for HCA. But my question to you is, I know that when you were facing or considering this mitral valve surgery that you were looking toward robotic. And my question is, have you thought about or why you might not have considered a good minimally invasive mitral valve surgeon as opposed to robotic, where they can still do a smaller incision, maybe not mid-sternal, again, because of recovery time and healing time?
It's a little staticky, but did you ask me why didn't I consider minimally invasive as opposed to
robotic? Yeah.
Mm-hmm. Robotic? No, that's what I wanted was the robotic. I was trying to find somebody that would do robotic.
There are many good surgeons that also do a minimally invasive procedure, not utilizing robots. They, obviously use their hands and their tools and their technique, but can also be done with a minimal, sometimes, sort of to the left side of your body incision instead of down the middle of the chest, which is, considering going through the sternum and such. So it was just a thought that came to me because of my background.
Well, that was going to be my second choice, because I wanted the robotic, but that would be my second choice, and I was not able to find anybody. I was searching, and on call, I did speak to people. I spoke to offices, and I actually spoke to a doctor's office who does what minimally invasive, goes through the side on the ribs, is Weston, the Cleveland Clinic. Is it that's the Florida Clinic? And they actually said, well, for mitral valve, he only does like one every couple weeks. You might want to find somebody that is more experienced.
Yeah. I understand. Yeah, I understand that. But, well, thank you. Yeah, I appreciate your opinion on that. And, I'm sure Dr. Harrison, I'm sure knows many people in the CV surgery world. And I'm sure there's some good mitral valve, minimally invasive procedural physicians out there. So.
Right.
So, Janet, it's disappointing that no one would offer her CT MRI, refer over here to have that, rather than do the Cath and TE, the more invasive procedures when she didn't need it. One, that's disappointing. The other disappointing thing is that none of the people that she saw at Northside would refer her for robotic surgery somewhere.
Minimally invasive. They told me minimally invasive. Two surgeons, one at Northside and one at St. Anthony's. The first one that wanted to do surgery immediately. Both of them told me that minimally invasive does not work. We didn't even talk about robotic. It does not work. The only way to have this surgery is to go in through the sternum. It's the only way to go. It's the only way they do it. And if there's nobody around that will do it. And then the doctor who did the TEE told me that if I don't want my sternum broken, then I need to probably go ST.
Yeah. Well, I mean, good for you, Susan, for being your own advocate. How did she get to you, Dr. Harrison?
So her colleague she works with is Jason McDonald, and he was my cardiac MRI tech at Northside when they had a cardiac MRI next door to the hospital in the office building.
That's how, and I actually called Dr. Harrison first, but he was away, and I couldn't get an appointment until June. I actually called probably mid-April. I was calling my doctors, and Jason, and I was not being happy with what some of the responses, and I was making appointments, and Jason heard me doing this on the phone at work and said, call the only guy that I would trust my heart with, and that's Dr. Harrison. And I called him, but he wasn't available, so I thought I was being smart by getting all the testing done and walking into his office with all this information about me, as opposed to just walking in and saying I have a murmur. But that's not apparently what I thought I was doing. Wasn't the best idea, but at least.
Yeah, but I think that along the way, Susan, you learn a lot about medicine and about your own health and your own condition, and more importantly, your own options. So although it's been a difficult course for you, you know, it's certainly been educational and trying to understand what's the best thing for you.
So it's interesting for the navigators to hear how difficult it is to navigate the system on your own.
Oh, yeah.
I didn't get any help. Actually, even the cardiologist I went to said he would only give me, he could tell me hospitals to go to. Well, all the hospitals he told me are the same ones I Googled. So I was on my own. I was calling hospitals all over on my own trying to get information. And that's where I got my information from.
That's great. Well, Susan, it's really interesting. It's such a terrible system. You almost need an ombudsman. It's so hard to navigate. And so, Susan, we're over to the physical exam part. Can you put the phone up to your heart and see if we can hear it? It's a pretty loud murmur.
Oh, okay. Hold on. I don't know if you'll be able to.
Well, we'll listen. Could you hear the murmur?
Was that me?
No, that was Dr. Harrison, I think.
That was Dr. Harrison. Yeah. I was faking it, and Janet caught me. No, we can't hear the murmur, and I was faking it.
I'm like, and to tell you the truth, I was thinking it sounds better.
Actually, she has a very loud murmur that you can actually hear tilting the stethoscope, and just the edge of it being on the chest, you can still hear it. So it's a very loud murmur. So let's look at some of her images. And we don't have her EKG because it never made it to me. I took a picture of it and tried to send it, but something happened to it. So let's look at her transthoracic echo. So hang on here. We'll take a look at that. So this was done at St. Anthony's. And so let's play this and see how it looks. And so there's your inferior vena cava. This is a substernal view. It looks like this is the last part first, I guess. And so the atrial septum, the left atrium is enlarged. The left ventricle looks like it's a little bit enlarged. It looks like it's contracting well. There's some mitral annular calcification. We'll deal with that in a minute. There's no significant tricuspid regurgitation. Left ventricle is beating well. And there's the jet of mitral regurgitation. Goes all the way to the posterior wall. It's very bright. We'll go back and show it once more time here. Here we go. We're going to show the jet again in this particular view. And there it is again, the jet of mitral regurg. And so here's the 3D image of the mitral valve. There it is, open. Doesn't look like it's quite closing. In the center there, it doesn't look like it's quite closing. So we're not sure exactly which leaflet, but I think the posterior leaflet sort of sags a little too much. And so here it is. Here's where the leaflets aren't coapting. And so this is the anterior mitral valve leaflet. This is the posterior mitral valve leaflet. This is the mitral annular calcification. And so they're not quite coapting there. And so there's a leakage that's coming along the interatrial septum and going to the posterior wall in this particular view. Seems like a very broad area of regurgitation. There's no calcium in the valve itself. Here's the aortic valve. Here's the mitral valve again. And this is the coaptation line. Now we're looking in the peristernal long axis view. There's the mitral regurg again. There are a lot of very bright echoes. Orange is towards the transducer, and blue is away from the transducer, and the transducer is up here on the chest. And so I think that the posterior leaflet just doesn't quite coap and actually goes a little bit too far posteriorly. And when it does that, it leaves a gap. And that gap is responsible for the leakage. Have any questions about this echo? And so there we are at the end of the echo. So you've seen the echo. Let's go over here and take a look at the trance esophageal echo. So here we go in the trance esophageal echo. A lot of bright. Oh, here we go. Here's the 3D image of the mitral valve opening and closing. It's hard to see if there's a problem with the coaptation in this particular view. I can't say that I see any kind of holes or anything there. I just see the commissure. Commissure line is along here, and so I can't tell you where the leakage is there. But here we can see the leaflets coming together. Here's a little cord. Looks like you snapped a cord. Because here's a little chordae tendineae that's going back into the left atrium. Let's take a look at it. You can see it sort of flip back. And so that's probably what happened is you snapped a cord, and that's probably how you got the mitral regurg, and that's why there's a sudden appearance of a murmur that you didn't have before. And let's go forward some more, and then we'll go backward again. So again, a lot of turbulence, a lot of mitral regurgitation. The right ventricular systolic pressure was normal. There was no pulmonary hypertension. The TEE for me doesn't really add a lot from the previous echo. Here's where it tries to close. There's a little cord. You can go back on that again and see the cord flopping around. There's a little piece of cord hanging on there, flopping around.
After the TEE, I was told I had a hole, and that was my problem, or either a congenital issue or trauma to my chest, which I know we went over and it's not there. But this was done two weeks ago almost, and it's still not dictated, and the doctor won't call me back to tell me the official result.
Oh, okay. Was he going to, did he set up a meeting with you or anything?
No, because he said he didn't read it yet.
Oh, so he's not, but there's a plan to get together with you and review the results?
Well, I guess. I'm not going to, but I'm waiting to hear from them. And I called a few times just I wanted to get a copy, and they said he hasn't read it yet, and he's going to be going on vacation. So I don't plan on going back, but I just thought it was interesting that I went through all this and I still don't even have a result.
I
The
understand.
hospital even said he didn't dictate it. The TE was done there, but there's no dictation. They never signed off on it.
I see.
No, I'm not going back.
Okay, so this is a very pretty images by 3D TEE. And so actually with the TEE, you have the TEE during surgery. And so when they do the robotic repair, there's a transesophageal 3D echo that's being done, that's being shown to actually show the results of the repair afterwards. So that's why I don't really do the TE, because they're going to do it anyway. And so my MRI shows the same thing and is very much equivalent for me. So I've nixed the TEE now. Well, nixed it a long time ago as unnecessary. So let's go look at your cardiac cath then. And so we have more than just the images for the cardiac cath. Of course, there's some pressure data. And the interesting thing for me about the cath is all this calcification of the mitral valve annulus. See all that heavy density, Susan? See that right there? That's calcification.
Can you point to where that is?
Yeah, let me go back on this one. We'll put a stop on it so we can stop it. This is the calcium in the mitral annulus. See these little lumps?
Okay. Yeah.
Yeah, and it moves up and down. And there it is over there on the right side. And so the coronaries, of course, are normal. And so the cath is useful for the coronaries. Certain age groups we require that. but of course we can get that from the coronary CT. The pressure data is useful, and we can go to the pressure data. Hang on, and we'll get back to our slides. But the pressure data can be gotten from the regular transthoracic echo, so we really don't need that either. So we don't need any of this data invasively when we can get it non-invasively. So the right atrial pressure was 8 millimeters. The right ventricular pressure was normal, 33/8. Pulmonary artery pressure was a little bit elevated, 43/18 with a mean of 28. Pulmonary capillary wedge pressure showed a mean of 22, but the V wave was increased, which is the regurgitant wave. It's not really a V wave, and that was 38 millimeters of mercury. The aortic pressure was normal. Cardiac output was reduced a little bit, and systemic vascular resistance, pulmonary artery pressure resistance is okay. So those are her numbers.
Dr. Harrison, this is Janet. I have a quick question on that. What is the last value, PAR 1.7 Wood units?
Yeah, so this is the this can be either in dynes per centimeter per meter, which is the conversion factor, or it can be Wood units named after Paul Wood, who did a lot of early cardiology in the 1950s and published a book in the 1950s, and this is all is left of him is the Wood units. We use these either Wood units or dyne centimeters, meter.
Right.
We use all that stuff when we're interested in people that are going to have lung transplants or heart transplants. And so that becomes extremely useful then. Most of the time, the rest of the time, we really don't use that much.
Yeah, I mean, I'm familiar with the dynes per meter squared, you know, so now that makes sense to me. Okay, thanks.
And there's a conversion factor, and I don't know why some people use Wood units still. I haven't seen it for a long time. Must be a computer printout. And so the plan, robotic mitral valve repair, and we're hoping that Didier will come in to discuss this in about the last 15 minutes or so from New York University. So we're going to show another case while we wait. And so if you hold on, please, we'll get our other case, and we'll show that while we're waiting for Dr. LeMay. So our next patient is a gentleman who had 2 episodes of severe chest pain. One recently when he was cutting grass. He's a 68-year-old retired male who was out cutting grass and had some chest pain. And then he had chest pain another time. He's not sure exactly when that was. And so he went and saw his doctor. His EKG was normal. His echo was normal. And so the doctor said, let's just do a CT and see what's going on, and bypass the middleman, which is the SPECT scan. And so we thought we would show this case out of interest. So we go directly to the CT and quit doing the nuclear test because of the 40% false positive, 65% false negative rate. And so you can see on his CT that we've got a plaque that's right here. So I just want to show you what these plaques look like. This is a non-calcified plaque. There's no calcium anywhere, and we can tell you a lot about this. Let's put some color on there. And there's the narrowing, and we can actually tell you more about the narrowing. Let's put this on here. There's the convergent divergent double cone that we talk about all the time. And we've got a diameter narrowing of 92%. 85% or greater is very significant, and a 99% cross-sectional area narrowing. And so this is a very severe area. And so we want to show you something about the composition of this plaque, since I'm very much interested in the morphology and composition of a plaque that would be causing problems. So let's come over here, and we'll get you pictures of that. And so you can see that this plaque basically has a lot of red stuff. So we talk about the fried green egg with ketchup. And so this is the fried green egg with ketchup, where the lumen is the green, the ketchup is necrotic core, the blue is fibrosis, yellow is calcification, which we don't really have much there. And so you can see how it narrows down and then gets larger again, and you can see how much necrotic core is in there that could easily rupture into the lumen and cause a clot, or it could just close down. And so the right corner is normal and the circumflex is normal. And so that's the main plaque that we find here, and obviously is the source of his symptoms. And so we can come over here and restore this. And there we are, the same image. And we can actually blow this up a little bit and look at this plaque. And we can move it along a little bit also and look at it. Hang on. And so this plaque is a very, very dangerous plaque, not only with narrowing, the convergent divergent double cone, but also the area of necrotic core. And so this, we'd like to compare that with the cardiac cath for you. So hang on here and we'll go find his cath. And so there's the same lesion popping out at you, very proximally. Here's the LV-gram, which shows that there's no damage to the anterior wall. It's beating very well. So it's proximal LAD after a diagonal vessel. The right coronary looks good. Of course, we knew all this from the cardiac CT. Actually, you could actually put the CT on, superimpose it on the image, not even inject the coronaries until you got to this stage, and then just go in and do angioplasty, because obviously a diagnostic cath is not much value if you got a CT that's equivalent. And so here we are with a wire across the diagonal vessel, a wire across the LAD, and a balloon that's been blown up. And then the balloon's down again. And now we're remodeling that with angioplasty and stenting. And it's looking pretty good, approximately, with the stent's in place. Looks like the stenosis is gone. There's a stent now. Wire still across the stent. The other wire has been pulled back because the diagonal vessel is okay and hasn't been shut down by this procedure. That's why the wire was put across the diagonal. And now we've got what looks like a normal vessel. Isn't that pretty? And the end result, angioplasty and stenting of that without any problems. So we just want to share that with you. Somebody comes along with chest pain, you do a CT, find the lesion, fix it. Pretty basic. And now we're looking to see if we can get Dr. LeMay. And so I'm going to call him.
Okay.
Okay, we have Dr. LeMay who's come on, and so we're going to get back to the screen we were looking at before. And so we'll take you back to the start of our slide deck. And so basically I have Susan Thompson with me today, and you basically are muted, so I'll unmute your microphone. So you can speak in your microphone instead of your telephone now if you'd like. Can you speak on your mic, Didier?
Can you hear me?
Oh, yes, and I'm going to hang up the cell phone. I can hear you quite well. So I just hung up the cell phone. And
can you hear me?
Yes, I can hear you well. And
okay, very good.
We have a conference going, and we have the fellows from Largo. We have the students, internal medicine from Bayonet Point, and we have our Care Assure nurse navigators online, and we have Susan Thompson on the phone as well as observing, and she's the patient. And so this is a story of Susan, and this is.
Oh, hi, Dan.
And so we will get Susan up here. And this is her story. She's 59 years old. She's an MRI CT tech from New Jersey who moved to St. Petersburg to work. And she was recently discovered to have a heart murmur, which apparently no one had heard before. And it was grade 5/6, so it's pretty loud. Everyone's hearing it. And then she's had the recent onset of some symptoms, including fatigue, falling asleep, palpitations, tightness, heaviness in her chest. And so she decided that she was going to find out more about this. And she had a echocardiogram, a trance esophageal echo, and a cardiac cath. The interesting story is that she has had Wegener's granulomatosis, which presented with some sinus ulcers. And she went on and had protracted high-dose steroids for a while. But the last 2 years, she's had only low-dose steroids of 2.5 up to 5 milligrams a day of prednisone. And most recently, she was weaned off the steroids in February and has been steroid-free for a couple months without symptoms. She has a history of having some blood clots when she was on birth control pills at age 18. And she has a past surgical history of hysterectomy, vein stripping, sinus surgery. She's allergic to iodine and was pre-medicated for her cardiac cath. And she has some fructose adverse reactions. And so on her physical examination, she has a very loud murmur that's easily heard. And her EKG doesn't show anything. It's entirely normal. But we'll show you her echo. So hang on for a minute and we'll get to her echo here. And here's her echo that shows her left ventricle is dilated, her left atrium is dilated. And we'll move forward. Normal sinus rhythm. And significant mitral regurgitation to the back of the left atrium with a large regurgitant jet. And let's see what we can make out about those mitral valve leaflets. There they are.
That's good. So what we're seeing here is a mitral annular calcification. The hinge of the posterior leaflet appears calcified. And the question is how much it extends into the leaflet and how much it extends into the annulus. So that's very important for the repair strategy.
So Dr. Didier is pointing out this heavy mitral annular calcification that exists, these big chunks of calcium that are in the mitral annulus. Now we're looking at a 2D view. You can go back.
That's preventive robotic surgery?
Well, we'll get into that after we see everything.
Okay.
No, it will.
Hang on here. And there's the aortic valve that looks nice. Tricuspid valve, left atrial enlargement, left ventricular enlargement.
So when that's a beautiful image. So when I look at here, it appears that the calcium seems to be below the posterior leaflet. and then there is a free leaflet here. It seems like this is most probably a muscular band, some kind of anatomic variation that got calcified, and we see that quite often. But the implication here is the leaflet tissue seems to be fine. The calcification seems to be localized below the leaflet tissue, so we can manage that. We have enough leaflet tissue here to do a good repair. Sometimes when the calcium, involved the entire posterior leaflet, then there's no enough tissue left to do a good repair. But that doesn't seem to be the case here. It's mostly a anatomic variation of the subvalvular apparatus.
So we can see lots of posterior mitral valve tissue and anterior mitral valve tissue. We can see the coaptation attempt. You may see some little cords hanging on there, perhaps. There might be a little slit in there. And then we're going to see the mitral regurgitation coming along here that's directed towards the septum. That's an eccentric jet that goes posterior to the wall. And so it's just slipping right here between that commissure, between these two leaflets. We've got this jet that's slipping in there because perhaps the posterior leaflet has gone too far and they're not coapting again. And we'll take it to the end, all the way through. And that's it. So we'll go to the Trance esophageal echo and see what that looks like. So we're loading that, and we'll let that play.
Okay, so when I look at this image here, my first question is what is the risk of postoperative SAM? Okay, we passed it.
Okay, so we're going to look and see if there's a subvalvular gradient, and if there's the mitral valve. Let's go this way. We're going to look at the left ventricular outflow tract and see. So hang on. This is as far. Let me take it back towards it goes, and then play it forward again. And we'll play it forward again. We want to make sure there's no systolic anterior motion of the mitral valve. There's the mitral valve in cross section. We'll accelerate it along here. Here's our 3D view, the coaptation line.
Yeah, so you see this this calcification here. It starts, it starts at the hinge of the posterior leaflet, and it goes down into the ventricle, and it's a muscle band that bridges the annulus and the papillary muscle that got calcified. and that's the cause of all the problems here. You know. The most common cause of degenerative mitral valve regurgitation is anatomic variation of the subvalvular apparatus. That's an interesting one. That's the one I need to assess the risk of SAM.
So we don't see any SAM here.
No, but sometimes after mitral valve repair, when you know, sometimes there's a postoperative SAM.
Yeah.
Especially if you use a prosthetic device that is too small for the patient.
Yes.
But here, I think the risk of postoperative SAM is very low because, I mean, there is a little bit of a sigmoid septum, but it's not bad. The ventricle is indeed enlarged, and that decreases the risk of SAM very much. And then we also look at the angle between the mitral orifice and the aortic orifice. The angle is a little bit, I would say, small, so that would be the only you know, sign that it raises a little bit the risk of SAM. But I think overall the risk of postoperative SAM is very, very low. We're more concerned about this today because with the early indication, we get people with, you know, small ventricle, very, very, very dynamic ventricle. So the incidence of SAM has raised with earlier indications. But in this case, it's you know, it's not. I mean, it seems like this mitral valve regurgitation has been there for a long time, and the ventricle has dilated. We're not in the chapter of early indication.
So Didier is looking at the possibility of systolic anterior motion of the mitral valve as a post-op complication, and he explores that on every patient. And this ventricle is dilated, and so that avoids it. And the angles look favorable for that not to happen. Frequently that involves a prosthesis. Sometimes post-op patients are put on a beta blocker to temporize for that. And it doesn't look like that's going to be foreseeable in this particular repair. And so, so we're happy with that, and looks like you can see sort of a gap there, and then there's a place where also it looks like there may be a little piece of a cord, like right there, maybe a piece of a cord that that's coming up there and flipping around. And so it could be, there could be a ruptured cord that's on the other side now. And so that's a possibility. And it sort of flips around over there. And so we'll play this back one more time. And you can go on and show you the cardiac cath.
It will be interesting to see how the calcification on the cath. That's where, you know, get a good sense of what's the extent of it.
We'll show you the cath calcification. Hang on here. What you'll be able to see, it's very heavy, and you do see it quite well. And so to go to the start of our cath, and there's the heavy calcification that's
along the circumflex artery, right?
Yeah, along the circumflex AV groove area. And there's some more calcification more distally. Calcification all along, most of the around the posterior leaflet, some around the anterior leaflet over here. Oh, so it's more anteriorly in this particular view. So let's go back one more time, and maybe we can get back to that area there and see it, and then we'll move forward into the left ventriculogram and look at it.
It was well here.
And here we are at the LV-gram, and you can see that exactly left atrium being very enlarged, left ventricle being enlarged, being a lot of mitral regurgitation. We can go back to that again. I'm playing the heart backwards, which doesn't happen physiologically, I hope. And there it goes forward again. And it shows that very well. Let's go back one more time. And there's the dilated left ventricle, dilated left atrium, calcium that's inferior ward of the posterior leaf of the mitral valve and the anterior leaf of the mitral valve. Looks like more calcium's over here than over there. There you go. So that basically, would you like to basically conclude here, Didier? I do have some Cath data, which is normal except for a big V wave. And so here is Cath data coming up. And the cardiac output is down, and the V wave's 38. Pulmonary artery pressure is slightly elevated. That should all return to normal after repair.
Okay, so there are two things that I mean make this case a little bit out of the a little bit different from the average. First of all, there's this mitral annular calcification that is going to make the repair a little bit more complex. And it's going to be on the complex side. But the repair is totally doable. We have to expect a cross-clamp time that will be like, probably 90 minutes, 2 hours, especially if we have to patch the ventricle. Sometimes, when we remove those calcification, the AV group could, require a bovine pericardial patch before resuspending the posterior leaflet. So, it will be like a cross-clamp time that will be longer than the average. The other thing, and I looked at it on the echo report, the left ventricular end systolic dimension was 4.3 centimeters. So, you all know that the systolic dimension is a very, very important predictor of postoperative left ventricular dysfunction. And when the diameter is superior to 4 centimeters, there's a very high risk of postoperative ventricular dysfunction. So I would not be surprised, Suzanne, that after surgery, your ejection fraction will probably go down to 40, 50, 45%, and then you will require some help with beta blockers and maybe ACE inhibitors to recover this a normal LV function. So these are the two things: a repair that is going to be probably on the complex side, or be cross-clamp time that will be a little higher than the norm, and probably some kind of LV dysfunction afterwards. Maybe it will not happen. It's not 100%. But in my experience, when people reaches a diameter and systolic diameter of above 4 centimeters, usually that's when you see those drop in ejection fraction after mitral valve repair, and the risk of postoperative SAM is low. We spoke about that, and I think you're a good candidate for robotic mitral valve repair, and then we hope for the best.
Susan, do you have any questions about how long you'll be in the hospital?
Yeah. How long I would be in the hospital? How long would I be able to go back to work? And how quickly can I get it done? I'm penciled in for August 9th, and it seems like forever away for you to do the surgery, doctor.
Yes, it will have to be, because the schedule is booked until then. You'll stay in the hospital probably 4 nights, and it will take you about 3 to 4 weeks to get back to yourself. But I think robotics eases the recovery. I mean, it's really the less invasive way of performing mitral valve repair, and it's also probably the most precise way. There's one thing that we did not discuss, Eric, is how much tricuspid regurgitation do we have? You know, I'm looking at the PA pressures here that are slightly elevated, and it would be nice also to get a sense of how much tricuspid regurg we have. I hope we don't have to do a tricuspid annuloplasty as well.
Yeah, I don't think so. I don't think that's a problem. So
Okay.
I don't think you have to worry about that.
Dr. Harrison, he's a little staticky, so I didn't hear what his response to
He was asking about if there was tricuspid regurgitation of any significance, and if you would need a tricuspid repair or annuloplasty, and I think not, and I'm not impressed with the right side of the heart being dilated, and I'm not impressed with tricuspid regurgitation.
Excellent.
So no problem.
I meant for hospital stay and how long to recover and those things. I couldn't quite understand them. Sorry.
Hospital stay. How long?
4 nights.
4 nights. 4 nights in the hospital.
Okay.
Okay.
All right. And how and when? Quickly. If there's any way I could get it done.
Can't get it done sooner. We can, if there's an opening in the schedule, he can have you on standby. But currently, he's pretty scheduled pretty tight because he's the best in the world. So that's what happens when you're the best.
And then 3 to 4 weeks, I should be able to go back to work. That's right.
Yes. Okay. Let's say 3 weeks from the surgery.
Okay.
That is correct.
Good.
So good. Well, I think we've done a great job, and I appreciate your doing a webinar with us during this conference. Susan, I think you have the bottom line there, and we're looking forward to you getting that done. And if there's any problems between now and then, you and I will address them, and we can get together again and talk a little bit if you'd like. And thank you so much for everyone coming to our conference. I hope we were helpful to you in understanding how this process goes about. It used to be a long time ago, the surgeon and the cardiologist and the patient would all meet together. Those times are long gone, and so I think we brought this back today with the technology that we have, and I'm really happy about that we can all communicate and talk about and exchange the information we need. So it's a new era of cardiology where we can all get together again like we used to. Thank you.
Well done. Thank you, Eric.
Thank you.
Dr. Didier, I already spoke to your office. I'll confirm that August 9th, and I'll ask to be on a standby if anything changes.
Okay. Thank you, Didier. Thank you, Susan. Thank you, Janet.
Thanks, Eric.
Melody. Thank you, Sharon. Christine. I think Bayonet Point. Largo. Bye-bye.
Bye-bye.
Bye.